And so I would like to share with you some of my thoughts regarding what industrial and systems engineering can bring to the conversation about re-engineering primary care. And Paul Gorman this morning said, Pascale, are you sure we want to re-engineer primary care? I said, yeah, sure. This is what we're here for. I mean, I think that if we don't take on that job and start talking about it and peeling the onions and coming up with clear ideas about how to move forward, I'm not sure that anyone else, I mean, maybe, yeah, there may be other people, but I think we need to do it. And I know Chris tomorrow is going to be talking about primary care and for the industrial engineers to better understand primary care, but just wanted to show you a couple of studies. People in primary care know that there are problems. That particular study was done by Nancy Elder, where she surveyed family physicians and asked them to record all kinds of different problems that they encounter during patient visits. And this is one of the tables from her paper. And as you go down the list, and as us on the industrial engineering side, we go down that list, it's like, oh my God, they don't have access to the information that they need to do their job, and they need to look for it. There are staffing problems, scheduling problems. There are problems related to the skills and knowledge that primary care clinicians need, problems of communication. And so as we go down that list, we can see a lot of opportunities for people in industrial engineering to help in setting up systems that can help solve some of these problems. And so system is really what I'm going to be talking about the rest of my talk. How many of you have seen that study? That was another interesting study, Too Little, Too Much. Was published in the archives of internal medicine a couple of years ago, where the primary care physicians themselves say in 42% of them say that there's actually too much care that's provided to patients. Only 6% of the primary care physicians say there was too little care provided to their patients. What's interesting is to look at, again, this is based on self-reports, look at what are the factors that primary care physicians identify in that providing too much care to patients. As you would expect, number 3 on that list, malpractice concerns, the idea of defensive medicine. But what was interesting to me was to look at the first 2 factors, inadequate time with patients. So there's too much that's provided, too much care provided to patient. At the same time, you don't have enough time. But if you really think about it, we know from, for instance, many human factors theories and models, we know that when people don't have a lot of time to perform a task, what happens is tunnel vision. Cognitive processing tends to be very focused and sometimes focused on the right thing. So what was happening in those visits is really, I'm going to order as much things as I can in order to be able to do things for the patient. So actually, not having enough time creates more work. In industrial engineering, there is a set of tools that we call system dynamics that can actually help understand some of these vicious circles or unintended consequences. The other big contributing factor that was mentioned by those primary care physicians, actually 52% of them, is the use of clinical performance measures. I mean, measuring is good, but then are you focusing your attention so much on the measures that you may be forgetting other things that are not being measured? And so maybe the check the box type of process. coordination, and I was going around the different groups this morning. I spent a little bit of time with the coordination group, and of course probably many, if not all of you, know the study that was published in JAMA a few years ago on missing clinical information. 14% of the visit don't have clinical information, and again, from an industrial engineering viewpoint, the system is just not working very well. Is not providing the information that people need to do their job. But in addition to that, they're spending additional time looking for the information. So it's like a lose-lose situation. When I went back and reread that study, the interesting thing is to look at what type of patients are more vulnerable to those situations. And I haven't listened to the group that looks at that's talking about health disparities, but new patients, recent immigrants, and patients with multiple medical problems were the patients where the clinical information was most often missing probably where you need it the most. And so we then think about health information technology. It's going to save us, it's going to provide the right information at the right time, but we know that there is a lot of work that needs to be done in designing and implementing health information technology. And I'm talking about that study, that JAMA study looking at primary care visits, but it's important for us to start breaking down some of the silos. And again, that's what we do as industrial and systems engineers, is we think about sometimes the big system, sometimes the small system, and then we think about how patients go through the system. And so very often the problems are across settings. And so we heard a lot about what happens in physician practices, whether they're internal medicine, family medicine, pediatrics, but there is also the home care environment and the information flow that needs to be well designed between the home environment and the medical environment, as well as across time. And I'm looking at Ellen Wald, the chair of pediatrics, because I think some of the interesting issues have to do with what happens to kids when they grow up and become adult, and then transition over that period of time of dealing with your pediatrician that you've known for quite a long time, and then moving in the adult medicine world. So we need to think about time in all kinds of different ways at all kinds of different time scales. I don't think there is any one of you on the primary care side that would disagree that workload is a big issue. Richard Barron wrote a really interesting piece in the New England Journal about what's keeping us busy. He actually did a time study on himself. So again, time study is one of the things that we do as industrial engineers. And it was just fascinating to look at the volume of activities that he reported in that editorial. And many of you probably have read the paper that John and a few others wrote on information chaos. So obviously there's something that we need to do, and a number of people have called for industrial and systems engineering to get involved in healthcare in general. The Institute of Medicine and the National Academy of Engineering in 2005, there you go, published that report on building a better delivery system. If you haven't read it, it's actually a nice compendium that describes the different ways that industrial and systems engineering can contribute to healthcare in general. And our colleagues, Patty Brennan and a few other people here at the University of Wisconsin, set up a workshop that was co-funded by AHRQ and the National Science Foundation. Again, a really nice compendium of what are many of the areas that industrial engineering can contribute to. Just a few weeks ago, again, we made it to JAMA. Two physicians talked about re-engineering U.S. healthcare, and I've actually highlighted some of their comments. One of them, which I think makes a lot of sense, again, to someone who's an industrial engineer thinking about system and how different pieces of the system interact with each other. And that's very often what we see as industrial engineers, is we see one change, another one. So these single incremental changes that really don't make sense as a whole to really solve the big problem. And so what these two authors talk about is really looking at the overall process. And instead of looking at individual tasks, is to really take a look at the entire care process and start asking ourselves some of the really difficult questions about why are we doing certain things. And so very often, I think that's a challenge for us in industrial engineering, is you grab any of us, we spend half a day at your facility, we're going to find all kinds of really interesting things that can be redesigned, that can be changed, but this is not really what you want to do with us. You want to build a long-term relationship with us so we can help you start asking some of these more difficult questions about why are you doing some of these things. And then we can help you design the systems to achieve those goals. Industrial and systems engineering have contributed to many different areas of manufacturing, all kinds of products, as well as healthcare. We've been around for quite some time. You might not think of us as being related to Frank and Lillian Gilbreth. And there's actually a very old movie that Frank and Lillian Gilbreth did of looking at surgery, and so really in-depth time study of surgery. On the human factors side, we've been doing research in healthcare for quite some time. Al Chapanis, one of our leaders in human factors, 50 years ago, conducted one of the very first studies looking at medication errors. I doubt that many of you have heard about it. Gabriel Salvendi, I think many of you probably know him. He's the guy who's the editor of the 2,000-page Handbook of Industrial Engineering. So Professor Salvendi, actually, when I was talking to him a couple of years ago, he said, and I'm not going to be able to redo his accent, but he says something like, Pascale, I was doing research on dentists years ago, and I was an assistant professor, and they told me that doing industrial engineering research in healthcare was not good. So then he moved all of his research to manufacturing. So we've been around for quite some time. We actually have a professional association. It's a professional association that's probably more active on the practical side as opposed to the research side. But our professional association has, like many professional associations, define our field. So the Institute of Industrial Engineers define industrial engineering as the we're kind of a different breed of engineers. I guess someone from our field could design something like that. Oops. But very often we design things that are not, you cannot see their processes and their socio-technical systems. And so there are these systems comprised of people, of supplies, of information, equipment, and energy. And so the other thing that sometimes can be confusing for many of you looking at us in industrial engineering is that sometimes we look like mathematicians, that we've got big complicated equations about modeling a process, but sometimes we look like a social scientist because we try to understand behavior. Where, I mean, again, if you think about a system where sometimes you need the quantitative modeling of a system and a process, but in healthcare, there are lots of people, therefore you need to look at the people and behaviors. What I think may be making it even more complicated, and I'm making things more complicated, don't worry, I make things a little bit simpler later on, is that you think that we call industrial engineering. All right? I actually went around the country, and industrial engineering is the name of the school at Purdue. Industrial and systems engineering is what we call it at Wisconsin, Georgia Tech, NC State, University of Southern California, and Virginia Tech. Sometimes you find industrial engineering and manufacturing engineering because a lot of our tradition comes from manufacturing engineering. So industrial and manufacturing engineering is what they call their department at Penn State. Industrial and manufacturing systems engineering is what they call their department at Ohio State University. In our field of industrial engineering, there is one component that's called operations research. And so some department, probably because they've got a big operations research, I want to be at the table, they call themselves industrial engineering and operations research. That's Berkeley. Industrial and operations engineering, that's Michigan. And then sometimes you don't even find industrial in the title, in the name of the department. That's management, science, and engineering. Where do you think that one is? The West Coast. Oops. That's actually Stanford, where they merge two departments. So we're making it a little bit complicated for you. The other thing that's important is we talk about industrial engineering. There's actually many, many different components of industrial engineering. And I just pulled out those components from one of our new journals, the journals, it's called IIE, Institute of Industrial Engineers, Transactions on Healthcare Systems Engineering. And that's how we organize the journal. John Fowler from Arizona State University is the editor. We have something that's called Healthcare Operations Management. Then we have something that's called Socio-Technical Systems Analysis, and I'm in charge of it, and I put in parentheses, that's human factors. We have something called quality engineering and looking at engineering statistics, statistical process control. Healthcare informatics, of course, we are pretty heavy users of data and information that we need in our models. And so healthcare informatics is a big piece of it. Many of our colleagues look at the decision-making process that is used by physicians or by healthcare organizations. So medical decision-making is also another area. And then some of our colleagues look at public policy and healthcare public policy. So that's one way that we describe the field in that journal. This is a different way, again, of describing our field, of looking at how do you design the system, how do you analyze the system, and how do you control the system. And human factors in that taxonomy is part of the system design tool. People who do modeling and simulation in this system analysis tool. Supply chain management, there's probably those terms that you've heard us talk about. System dynamics, medical decision-making is part of operations research. And of course, it gets a little bit more complicated when you think about the different levels at which we can do our analysis, our design, and our control at the patient level, the team level, organization, and the environment. And I wanted to show you the levels, again, to help you think about very often an industrial engineer is called to solve a small problem, and we'd love to do that. We've got lots of students that are very interested in solving problems, but I think what we hear about today and tomorrow is to come up with a research agenda. So what are some of these bigger problems that may be at a patient level, at a team level, organization or environment level, and then the connections between the two. So what we all have in common in that domain of industrial and systems engineering is we're systems thinker. I mean, you talk to any of us, again, I come from a human factors background, so I look more at the people in the system. Some of my colleagues who do simulation might look at flow modeling and things like that. But one of the things that we have in common is we think about systems. So I'm looking at all of you right now, and I see a system. I see people that are connected, that are in a physical environment. And so that's how we think about things. The Institute of Medicine and the National Academy of Engineering, talking about silos at the National Academy level, they actually have come together to set up a number of initiatives, including that particular initiative that's looking at systems approaches for health innovation collaborative. This is industrial and systems engineering. That's what that's all about, is really how do you design the system, the healthcare systems, in order to solve or contribute to some of the problems that Caroline Clancy was talking about. And really, again, looking at it from an industrial engineering viewpoint, what we see is you are bombarded, and you name it. I mean, probably the list is much longer than that, but you got the National Quality Forum that's coming up with their 20 things. AHRQ came up with their own revised list of patient safety practices, the Joint Commission, and you've got meaningful use 1, 2, 3, 4, 5, 25. And so you're bombarded with all kinds of things. And then you're trying to integrate all of these things in your daily practice. And sometimes what it translates into is that sea of yellow. So let me just spend a couple of minutes talking about that. And there may be some people who've encountered the sea of yellow. Oh, I see Anne smiling, John smiling. Yeah, okay. All right, you're wearing yellow, Shana, come on. So the sea of yellow is your primary care physician, ready to meet with your patient, and you're working in a very efficient and effective healthcare organization that knows that you need information about what you need to do to your patients. And that healthcare organizations is in the process of mining data into the EHR, and what they've done is then show you all of the things that you need to take care of that particular patient that's in front of you. So we've actually worked with one healthcare organization and we visited some of their primary care practices, and that's what they were calling it, that EHR window that shows up with the 5, 25, 2 things that I need to do regarding best practices, health maintenance alerts, and so on. And remind me how much time do you have? 10 minutes. It's just not possible, or 15 or 20, depending on the type of patient. So there has to be just a better way of doing things as opposed to keep throwing things into the system. Again, from an industrial engineering, that just doesn't make sense. That black box model is just not going to work. Keep putting interventions, patient safety practices, alerts, and whatever in the system is just not going to work because healthcare is much more complex, and primary care has its own complexity, and some are listed on this slide in red. So we got to start thinking about what is the system. I was at a conference a couple of years ago, and one of the main people who writes about systems started saying we should not use the term anymore. And the reason she was saying that is that it's a very abused, misused term. And so I just wanted to spend some time talking a little bit about what are the fundamental characteristics of a system. And you might shake your head and say, that really doesn't exist in primary care, but maybe we can start getting there. So a system has a goal. I mean, there is a focus. If you're not able to tell us why you want to do something, then you got to do something else. And there are ways, there are techniques and methods that industrial engineers can use to help you figure out some of the goals and looking at trade-offs between goals. Looking at cognitive rank analysis, for instance, is one tool that we use in human factors. But without that clear goal, is forget it. I mean, there is no way that then we can really work with you. So that system, then when you define the goal, then it kind of defines the boundaries around the system. And those are really difficult to define because very often the interfaces between different systems is where the problems are. But you got to, make up your mind and tell me what those damn boundaries are, and maybe we can figure that out. But defining the boundaries of the system is pretty important. When we talk system, we're talking about elements. And again, one of our strengths is to understand the elements, but more importantly, the interactions between elements. And again, that's what a system thinker does, is looking at interactions between elements and looking at the whole of the system. Because without looking at the whole of the system, then you're going to miss those emergent properties. And so a system that functions well is probably not, especially in a complex environment of primary care, the system that functions well is not because one component works well. Forget it. So there has to be some good interactions between the different system elements. So in our program, we've developed and used that model, which we call the systems engineering initiative for patient safety model, that look at systems in terms of the people in the system, and the people could be individuals, physicians, nurses. Remember, there are other people who work in healthcare, receptionists, technicians, housekeeping. All of these people are really important. People could also be the patients, their caregivers, and the families and friends. They perform a number of different tasks, so they do things. We need to define those activities as they relate to the goal of the system. They use different tools and technologies, and that's what a couple of the groups are talking about. How do we design health IT to support the work system? All of that happens in a physical environment, and we know, again, this is sometimes something we forget, but the physical environment, the physical layout has tremendous impact on communication, whether people talk to each other. And of course, the organization also has an important role in defining procedures, schedules. So one of the groups is looking at scheduling and access. And we use all of these system characteristics to understand care processes. And because it's healthcare, of course, the patient outcomes are important. But without the workers come on, I could figure out a way of automating John Beasley or Sally Kraft or Ellen Wall. No, maybe not. And so without the workers in the system, it's just not going to work. And so then we also need to figure out how to design systems so people thrive in those systems. If I'm frustrated, I'm tired, burning out, all of these things can be huge problems. So just designing systems for one category of people at the expense of the other category is just not going to work. So we need to think about all of the people in the system. So my last slide is really implications, and I'm talking to the industrial engineers here in the room. But I hope that the primary care people would help us a lot. There's no way we can do that without partnering with primary care. And what I mean by partnering is not just we're going to meet and talk for an hour. I mean real partnership, which means on our side, investment. We're going to come to your place. We're going to shadow you. We're going to talk to you. We're going to read your literature. And so then that means a commitment on your side that you really want to work with us. So you see the two little guys or the two little figures. Sometimes one is pushing the other. So I don't know which one is pushing the other. But without that really true partnership, we're not going to go anywhere. So if I tell you I'm going to come and I'm going to fix your system, don't believe me, this is not how it's going to happen. And if you think on the primary care side that, well, maybe you can do some of these things on your own, but when you get to some of the tougher problems, you're going to need more expertise. So it's really a partnership. The other thing is that I talk about system, but we know that the system is big, and so you're going to have to figure out how to take some pieces of it. And so that's what I was talking about earlier. Help me define the boundaries. And as long as you know that that's the boundaries, then we know. And then we can work on that piece. But again, the goal is really to redesign entire processes. And finally, we may not look different. Some of us have a funny accent, but I'm sorry, we are different. There are huge cultural differences, and there are cultural differences in the language that we use. There are huge differences in how we look at things. And so trying to break some of these cultural differences, I think, is a goal for today and tomorrow. And I think our dream, or our big goal, is really to move on that path of we're next to each other, primary care and industrial engineering, multidisciplinary research. We're working together, interdisciplinary research, and we're exchanging papers and we're reading each other's literature. We're publishing in medical journals, and the primary care folks publish in our journals. But then trying to reach that transdisciplinary research stage is really what we aim for. And hopefully we can get there and start on that path today and tomorrow. So thank you very much.